Myself, Dr. Yukta Patel, first year DNB resident at Choithram Netralaya, Indore. Today, I am going to present a rare but an interesting case of a viral retinitis in an immunocompetent male. So, a 35-year-old healthy male presented to our OPD with a complaint of diminution of vision in his right eye since 3 days. He had a past history of fever with chill in his past week, which was treated locally. His best corrected visual acuity in the affected eye was 2/60. Intraocular pressures were within normal limit. Anterior segment findings were also within normal limit. So we did the posterior segment evaluation of the affected eye, which showed blurring of the disc margin. There were sheathing of the blood vessels seen. There were superficial and deep hemorrhages seen, and there were exudation seen at the posterior pole. There was also posterior hypopyon seen, which was due to the accumulation of the exudate. So we decided to do OCT of the affected eye, which showed hyperreflective cells. There was an elevated membrane over the retina. There was intraretinal fluid and edema. And there was inner layer hyperreflectivity, which suggests inner layer ischemia. So based on the clinical examination, we had following differentials in our mind. So we decided to do investigation for various bacterial and viral infections, which came out to be negative. HIV was negative, syphilis was also negative. CDR count were also within normal limits. So we decided to do AC tap for PCR titers, and to our surprise, it came out to be positive for both CMV and VZV infection. So based on the clinical examination and lab reports, we came to a provisional diagnosis of CMV and VZV retinitis in an immunocompetent male. So we started our patient on tablet valganciclovir 900 milligram BD along with the oral steroid as an induction dose. 1 week later, patient came to our follow-up with the deterioration of the vision to hand movements, which was due to the immune-mediated reaction in the patient due to the immunocompetent status of the male. But we continued with our antiviral therapy and steroids. So we could see gradual clearing of the vitritis and improvement in the vision of the patient. We can see the diminution in the vitritis. But the patient at 1 month came with the complaint of constant flashes in front of eyes. So we examined the posterior segment and we could find exudate clogged in the posterior segment. We couldn't find any retinal breaks in the posterior segment. So we decided to take the patient for vitrectomy. And intra, we could find a horseshoe-shaped retinal detachment, which was intraoperatively lasered. So after vitrectomy was done, the media became clear, the vitritis settled, and hemorrhages and exudate were also cleared. But there was a macular scar at the site of the origin of the infection, which was responsible for the low vision of the patient. On doing OCT, we can see the outer retinal necrosis at the site of the infection, which was responsible for this low visual acuity of the patient. So this is the post-op image of the patient at 4 months. We continued our antiviral therapy for 3 more months and tapered down the steroids. And at 1 year follow-up, the patient ocular conditions were stable. Thank you.
I think it's a very, very good case presentation because they are really a diagnostic dilemma, and you were brave enough to do a AC tap and find out the diagnosis itself. And of course, yes, it's very important to start steroids as well after 1 week of cover of antivirals. That's a very important message as well. And if they do not clear, then vitrectomy, and then because the retina is weak, there could be a break, and that needs management itself. Though the patient did not gain good vision, but I think it was a very well managed case.